Bismillah ar-Rahman ar-Rahim. Now we will talk about infertility. Infertility, inability of the couple to achieve pregnancy in spite of irregular, unprotected intercourse within a reasonable period. Usually this period is about 1 year. 10 to 15% of all couples trying to achieve pregnancy are infertile. This means that 1/10 to 1/7 of marriages are involuntarily childless. Normal human reproduction necessitates anatomical and functional integrity of the following factors: semen, sexual relationship, normal cervix uteri, normal corpus uteri, normal functioning fallopian tubes, functioning ovaries, and normal pelvic peritoneum. Generally, the male defect is responsible for infertility in 1/3 of couples, and the female defect is responsible for infertility in 1/3 of couples, and the combined defect in both male and female in 1/3 of infertile couples. Still, unexplained infertility exists in 10 to 15% of infertile couples. The Tubal factor defect is responsible for 20 to 30% of the causes of infertility in the female. The anovulation is responsible for 30 to 40% of infertility in the female. Endometriosis is responsible for 10 to 15%. Cervical factor defect is responsible for 10 to 15%. Uterine factor defect is responsible for about 5% of female infertility. Endometriosis exists in about 40% of infertile females, but estimated to be the sole cause of infertility in up to 50% alone only. The first item to be discussed as a cause of infertility is the semen. The abnormal spermiogram is responsible for 1/3 of infertile couples. WHO criteria of normal semen before the count was up to, there are 3 important criteria, or actually it is 4 important criteria: the semen volume, the count of sperm, the motility, and the morphology. The normal volume is not less than 1.5 millimeter. The count, before it was 20 million or more in milliliter. Now up 15 million per milliliter is acceptable. Before it was 20% of the sperm are actively motile, and about more than 50% actively and progressively motile, either rapid or moderate. Now this is changed to only progressive motility in up to 32%. The morphology depends whether the semen analysis was performed manually or by computer. Manually, 70% at least should be normal. This is a picture for the seminiferous tubules and the development of the sperm from the spermatogonia up to full motile sperm. The second factor responsible for infertility is the marital relationship. These are the important items for the marital relationship. It is the frequency, time, and timing of intercourse, impotence, premature ejaculation, unejaculation, retrograde ejaculation, postcoital douching, spermicidal lubricants, and vaginal abnormalities. All these are important factors for as when we consider the marital relationship. Some people, they have a abnormal fault idea about the proper timing for ovulation, so the intercourse may occur directly pre or post menstrual, avoiding the intercourse and the mid cycle, which is the proper cycle for occurrence of pregnancy, and so on. Most of these marital relationships can be evaluated through history taking, mainly through history taking, through clinical examination for the cases of vaginal abnormalities or penile abnormalities, and the most important investigation to confirm the adequacy of marital relationship is the timed postcoital test. This means after intercourse, you take a sample from the cervical mucus from the cervix and examine it under the microscope to see the arrival of the sperm to the cervical canal and the number of the sperm, the motility, and the presence of any infection of the cervical mucus. The third item is the cervix, uterine cervix. Uterine cervix defect is responsible for about 10 to 15% of infertility in the female. At first, we have to consider the physiologic functions of the sperm, of the cervix. The physiologic functions of the cervix are sperm transport, sperm nourishment, filtration, sperm reservoir, sperm capacitation, and the cervix acts as a timed valve, allowing the sperm ascent of the sperm only at the time of ovulation. For the cervix to achieve these functions, we have to consider the position of the cervix, the patency, and the cervical mucus, the quality and the quantity of the cervical mucus. This the adequacy of cervical factor can be tested through history taking, meaning the mid-cycle cervical secretion, the presence of manifestation of cervical infection, the previous operations of the cervix, and the utilization of medications which may affect the quality and the quantity of cervical mucus. Secondly, for evaluation of the cervical factor is the clinical examination. Firstly, we said the history. Secondly is the clinical examination to examine the position of the cervix, sounding for the patency, presence of gross lesions on the cervix, manifestations of infection, and the mid-cycle cervical mucus examination. The third item to evaluate the cervix is investigations. The most important investigation is the timed postcoital test. Treatment of the cervical factor. There are some lesions need surgical treatment, like the cervical polyp, cervical erosion, which needs cervical painting with silver nitrate, and presence of cervical adhesions or atresia or something like that. The second item is to improve the quality of the cervical mucus through treatment of any infection and utilization of estrogen therapy. Third item, for nullification of the effect of cervical factor defect is resorting to intrauterine insemination to bypass the cervix and inject the spermatozoa directly in the uterine cavity. The corpus uteri or the uterine body is responsible. The defect in the corpus uteri is responsible for about 5% of the female infertility. The main functions of the uterine cavity is a sperm transport, providing a place for implantation of the growing embryo and baby, support of the growing embryo and baby. These functions can be achieved through presence of functional, properly vascularized endometrium and undistorted uterine cavity. So any factor affecting the normal function and vascularization of the endometrium or distorting the uterine cavity will interfere with the function of the uterine body. The main insults which may disturb the functions of the uterine body are the presence of fibroids, intrauterine adhesions, adenomyosis, uterine malformations, and luteal insufficiency due to endometrial defect. The corpus uterine evaluation depends mainly on the history, mainly presence of abnormalities in the uterine cavity usually will affect the amount of menstrual blood flow by increasing it or decreasing it, either menorrhagia, metrorrhagia, hypomenorrhea, or amenorrhea. So, to take an idea about the function of the uterine cavity, look to the amount of menstrual flow. In presence of abnormality in uterine cavity, this amount of menstrual flow will be affected either by increasing the amount or decreasing the amount. Also, the presence of pelvic pain and pelvic heaviness, presence of abdominal or periabdominal mass, compression manifestations mainly on the bowel and urinary tract, previous uterine operations, premenstrual spotting, short luteal phase, and manifestations suggested of adenomyosis or pelvic endometriosis. All these factors can be evaluated through proper history taking. Then, the second item for evaluation of the uterine body is the clinical examination, palpating the uterus by manual pelvic palpation, palpating the uterus, presence of any uterine masses, and uterine sounding. The third item is investigations for the uterine body. The most important investigations are ultrasound examination, hysterosalpingography, and hysteroscopy. Premenstrual endometrial biopsy is needed only for evaluation of presence of chronic endometrial infection or the luteal phase defect. Treatment of uterine body defects mainly surgical. In most of the cases is surgical, like polyp, uterine fibroid, intrauterine adhesion, septum, or adenomyosis. The treatment of these lesions is mainly surgical. In some cases, hormonal treatment may be beneficial for treatment of luteal insufficiency and adenomyosis. This is hysteroscopy, performing hysteroscopy for evaluation of the uterine cavity. This is the normal appearance of the uterine cavity and cervical canal. This is the presence of uterine septum. Presence of uterine septum. This is how to excise the uterine septum through the hysteroscope. This endometrial polyp and how to excise it with the hysteroscope. This is intrauterine adhesions, presence of intrauterine adhesions. And these are how to excise this adhesion also through the hysteroscope. This is endometrial polyp or endometrial fibroid polyp or something like that. It's fibroid polyp. This intracavitary fibroid and this submucous fibroid both can be excised easily through the hysteroscope by chafing it with a loop like that through the hysteroscope. Now, the fallopian tube, which is responsible for 20 to 30% of female infertility. This is a picture clarifying the function of the fallopian tube for oocyte capture then preparing site for fertilization. This is all site capture, site for fertilization, and site for early embryo development and early cleavage till the blastocyst stage. Then after that it comes to the uterine cavity. This journey in the tube takes about 5 to 6 days. The tube have to furnish to provide a place for achievement of all these functions, including ovum capture, fertilization, ovum capture, passage of sperm, fertilization, early embryo development, then transport to the uterine cavity. All these functions occur inside the tube. And this needs healthy endocervix or endosalpinx, endosalpingeal lining of the tube, healthy tubal musculature, healthy finger-like fimbrial end of the tube, and patency and free mobility of the tube. This should be present for the tube to perform its normal function. This is a picture for presence of peritubal adhesions which are limiting the mobility of the tube, disturbing it to perform the function. And this also fimbrial phimosis. Picture we can see fimbrial phimosis with narrowing of the fimbrial end and distortion of the fimbrial structure. The main functions of the tube, as we said, ovum pickup, sperm transport, capacitation in the reservoir, fertilization, embryo support, and transport. For the tubal function to be done, that there should be luminal patency of the tube, tubal mobility and contractions, no adhesions limiting its tube. Distal end of the tube is normal with its highly specialized fimbrial construction, tubo-ovarian ligament and fimbria ovarica, normal endosalpinx with its mucosal fold pattern, cilia and mucosal secretions. The surrounding pelvic peritoneum should be healthy without presence of adhesions or presence of pelvic endometriosis, and the surround ligaments of the tube should be normal. The main insults which affect the tube are the previous pelvic infection, previous pelvic operation, endometriosis, previous ectopic pregnancy, congenital anomalies, mainly the hypoplastic tube, tubal sterilization, salpingitis, ismica nodosa, and pelvic TB. These are the main insults which may affect the tube. The most important of them, previous pelvic operation, previous pelvic infection, and endometriosis. These are the most frequent. Also, previous ectopic pregnancy can be considered as a frequent cause. For evaluation of the tubal factor, the history taking is very important to inquire about the previous pelvic operation, previous attack of pelvic inflammatory disease, previous IUCD application, abortion, complicated delivery, or uterine instrumentation. All this may lead to ascending infection which may affect the tube. Symptoms or suggestive of endometriosis. We said that the most important items is the pelvic operation. We can inquire it through the history. Attack of previous pelvic infection, we can inquire it about through the history. And the symptoms suggestive of endometriosis also can be clarified through history taking, like dysmenorrhea, dyspareunia, dyschezia, and pelvic pains, or previous history of chest TB, which may affect the tube. Tubal factor evaluation, second item is the clinical examination, concentrating on the presence of abdominal scar, fixed retroverted uterus, presence of fixed tender adnexal mass, painful nodules in the Douglas pouch or the rectovaginal septum, bluish nodules in the vaginal vault. These three last items may refer to the presence of pelvic endometriosis. Investigations. Most important investigations for evaluation of the tubal factor are the hysterosalpingography, laparoscopy, hysteroscopy, and the tubal cannulation. They are the main items for evaluation of the tubal factor. The treatment of tubal factor, one of two items: either surgery for correction of the distorted pelvic anatomy and the tubal anatomy, and this can be successful or not according to the tubal condition. And the second item is the second line of treatment is resorting to assisted reproductive techniques, mainly IVF and ICSI. So whatever the tubal condition, we have only two options for treatment: surgical or microsurgical treatment, either through the laparoscopy or open microsurgery, or the ART, resorting to ART procedures. This is the performance of hysterosalpingography, and these are samples of the hysterosalpingography pictures. One picture is demonstrating uterine synechia, the other picture demonstrating proximal tubal obstruction in one side and hydrosalpinx in the other side. One picture is demonstrating, it may not be clear, but it is for submucosal myoma and patent tubes. The last item for infertility is ovulation. Anovulation is responsible for 30 to 40% of female infertility. In considering ovulation, we have to consider three important questions. Whether ovulation occurs or not, in case of ovulatory woman, is the luteal phase is adequate or not, in case of anovulation, which type of anovulation, and what is the exact etiology. So we have three questions to be answered: ovulation occurs or not, if there is anovulation, which type and what is the exact etiology, and if ovulation occurs, the luteal phase is adequate or not. We have three forms of anovulation: hypergonadotrophic, which means ovarian failure; normogonadotrophic, as in cases of polycystic ovary syndrome and polycystic ovary-like syndrome; and the hypogonadotrophic anovulation. This means pituitary hypothalamic dysfunction. This is a normal menstrual cycle with the hormonal changes, endometrial changes, and follicular changes. The detection of ovulation, whether ovulation occurs or not, depends on the history, mainly considering whether the cycle is regular or not. The regular cycle is mostly ovulatory. The irregular cycle, as in case of oligomenorrhea, amenorrhea, or polymenorrhea, means ovarian problem. So, by a simple question for the patient, asking her about the regularity of the cycle, you can have an idea about this woman is ovulatory or not. If she has irregular menstruation, mostly ovulatory. If she has irregular menstruation, this means it's mostly anovulatory. The presence of mid-cycle pelvic pain, increased mid-cycle cervical secretion, presence of premenstrual and menstrual symptoms, these items means also she is ovulatory. This means that in the presence of regular cycle, presence of mid-cycle pelvic pain, mid-cycle increase of cervical secretion, premenstrual and menstrual manifestations, this mostly refers to an ovulatory woman. Detection of ovulation, also through investigation, we can perform ultrasonic folliculometry. Usually This is the most important item and rarely are resorting to other measures to detect ovulation. Progesterone assay, mid-luteal progesterone assay, basal body temperature chart, detection of LH surge, premenstrual endometrial biopsy. These are all possibilities to take an idea about ovulation, but the presence of a simple maneuver easily available like the ultrasonic folliculometry. Mainly now we are depending on the ultrasonic folliculometry for detection of ovulation without the need for resorting to other maneuvers. A detection of luteal insufficiency, this can be detected through history. In the presence of luteal insufficiency, you will have two important things in the history: the premenstrual spotting. This refers to luteal insufficiency or the short luteal phase. These are manifestations of luteal phase insufficiency. This can be detected also through investigations like premenstrual endometrial biopsy, progesterone assay, and basal body temperature charts. The most important is the premenstrual endometrial biopsy for endometrial dating and detection of luteal phase insufficiency. Detection of type and the etiology of anovulation. The main investigations are FSH, LH. This will categorize the patient whether she is hypogonadotrophic, normogonadotrophic, or hypergonadotrophic, as we said. Prolactin for detection of hyperprolactinemia, which may be the cause for anovulation. In this case, the case will be normogonadotrophic hyperprolactinemia. 17 alpha hydroxyprogesterone assay. This helps for detection of congenital adrenal hyperplasia. Androgens, mainly important for detection of PCO and for detection of adrenal defects. Thyroid function tests in cases of the thyroid is responsible for the ovulatory dysfunction, and cortisol for when the adrenal dysfunction is responsible for anovulation. These are the detection type and the etiology of anovulation according to clinical findings. These are marked obesity can be the cause, anorexia nervosa, this refers to hypothalamic defect, specific syndromes like Kalman syndrome, Sheehan syndrome, and these are refers to pituitary defect, Cushing adrenal defect, galactorrhea responsible for inappropriate galactorrhea, Turner phenotype, CNS manifestation, and so on. All these are clinical findings which may pinpoint the type and etiology of anovulation. Treatment of anovulation, at first to categorize the patient. If she is hypergonadotrophic anovulation, this means ovarian failure, and this means mostly no treatment. Hypergonadotrophic anovulation means ovarian failure, means mainly no treatment. And this is the value of measuring the gonadotropins to detect the type and put out the cases of ovarian failure. And if the case is hypogonadotrophic, means we are resorting to gonadotropins for ovulation induction. If she is normogonadotrophic, like the cases of polycystic ovary syndrome, hyperprolactinemia, thyroid dysfunction, all these are normogonadotrophic anovulation and can be corrected with in cases of galactorrhea with correction of the hyperprolactinemia. In cases of thyroid dysfunction can be corrected with the correction of the thyroid function, and in case of polycystic ovary syndrome with ovulation induction. And for ovulation induction we have several oral medications like the clomiphene citrate or aromatase inhibitors. We have the gonadotropins like HMG or FSH, recombinant FSH. We have gonadotropin releasing hormone, and we have in some cases ovarian drilling, in some cases of polycystic ovary syndrome. And also in cases of luteal insufficiency, we have to support luteal phase with progesterone. These are the most important items, and in this, the most important in this to decide whether ovulatory or not. If she is anovulatory, whether hypogonadotrophic, normogonadotrophic, or hypergonadotrophic. Hypergonadotrophic usually ovarian failure, no treatment. Hypogonadotrophic usually central pituitary hypothalamic, and this usually needs gonadotropin. Or normogonadotrophic can use oral drugs like clomiphene citrate or letrozole, or also gonadotropin. So it is very important to decide the type and the etiology of anovulation. Lastly, these are pictures clarifying how we are doing the ART procedures and intrauterine insemination. This is how the intrauterine insemination is done. Usually, intrauterine insemination is done in conjunction with controlled ovarian hyperstimulation. This is how we are preparing the semen with swim up technique, and how we are injecting the semen in the uterus through a catheter, specialized catheter for intrauterine insemination. And this is the ovarian stimulation techniques, different techniques using gonadotropins, gonadotropin agonist or gonadotropin antagonist. There's different protocols for stimulation, as this is how we can take the oocyte from the ovary, performing oocyte pickup through vaginal ultrasound with a needle fixed to it, and under ultrasound guidance we can go through the vagina into the ovary with the needle and aspirate the oocytes. This is the laboratory work, how you can evaluate the oocyte, the mature oocyte as it's seen, and then preparing the sperm. Then for either we are performing IVF, putting the sperm with the oocyte in the same tube, test tube, or we are performing ICSI by injecting the sperm in the cytoplasm of the oocyte. Then after that we are controlling the fertilization after 18 hours, and then controlling the division after every day for detection of the growing embryo. And this picture for oocyte, how you are injecting it through the micromanipulator, and how in day one this is the two nuclei, means fertilization. Then after that division, 4 cell stage, 8 cell stage, and so on. And these are, one is the germinal vesicle, means immature oocyte, metaphase oocyte, metaphase 1 oocyte, and this metaphase 1 oocyte still immature. 3 pronuclei fertilized oocyte, this means oocyte fertilized by 2 sperm in case of IVF. This is faulty, cannot be transferred. And this fragmented embryo, this also poor quality embryo, cannot be transferred. Vacuolated oocyte means poor quality oocyte. And day 2 multinucleated embryo, also a faulty, cannot be transferred. This is a procedure how performing the embryo transfer. The picture how we are loading the caster with the embryos, and then how we are passing under ultrasound guidance the transfer caster into the uterine cavity to deposit the embryos in the uterine cavity. This is also, there is an option of cryopreservation of extra embryos. This is also an assisted hatching. Assisting hatching means you are assisting the release of the embryo from the zona into the uterine cavity, and this can assisted hatching by zona drilling or zona puncture, and now these are performed by laser technique. This assisted hatching by performing zona drilling, which helps the hatching of the embryo. This is also an option pre-implantation genetic diagnosis, which is helpful for detection of chromosomal abnormalities and some genetic abnormalities. This is performed before, also can be performed for sex selection, performed in day before transferring the embryo, and selecting helps for selection of the normal embryo from non-normal from the abnormal embryos, and transferring only the normal embryos. Thank you for attention.